Hello viewers, welcome to another episode of Healthy India. Today we'll be discussing anemia, in particular focusing on women. Our blood plays many roles in our body. It's a mix of fluid, which is commonly called plasma, and there are a lot of cells in that fluid, including red blood cells, white blood cells, platelets, and others. The red blood cells have a pigment called hemoglobin in them, which carries oxygen to various parts of the body. If there is a lowering in the number of red blood cells, and therefore the hemoglobin, so that various parts of our body do not get enough oxygen, that obviously will be detrimental for our health. So it is this deficiency of red blood cells actually that is called anemia. And you're all familiar with the term anemia. Different studies have shown that up to 30% of the world's population might be anemic. We'll now talk about anemia in women with two experts in our studio. We have with us Professor Tulika, Seth, who is the Chief of Hematology at the All India Institute of Medical Sciences, New Delhi. And we have Dr. APARNA Sharma, who is Additional Professor in Obstetrics and Gynaecology, again at the All India Institute of Medical Sciences, New Delhi. So what are some of the common causes of anemia, Dr. Seth, especially with regard to, in general, but especially with regard to our country?
So the commonest causes of anemia are nutritional, and in that predominantly it's iron deficiency anemia, but also other vitamins like vitamin B12 and folic acid can also cause anemia. So that's a large group, but there are also anemias which are due to diseases. So there are diseases like hemolytic anemias, of which hemoglobinopathies like thalassemia, sickle cell are very important. There are also other inherited conditions which can lead to anemia, which are like hereditary spherocytosis, G6PD deficiency. So it's very important to not forget that all anemia is not iron deficiency anemia. And then there are many other conditions like patients who have infections and infestations like malaria and parasitic infections, or even anemia of chronic disease. So patients who are suffering from any chronic disease, whether it's renal failure or other chronic diseases, can also have anemia. So there are multiple causes, and it's important to make sure that you know what the etiology is. Once you know the cause of the anemia, then the treatment can be done in a satisfactory way.
But you do feel that nutritional anemia is the dominant cause of anemia. Any particular reference to women here?
Definitely. So unfortunately, women menstruate. And because of that, their iron requirements are much higher than those of men. So it is very rare to see iron deficiency anemia in a man unless they're having large gastrointestinal losses. But women often in our country, also because of the menstruation and also because of a lot of food practices, often succumb to the iron deficiency and other vitamin deficiencies.
So I'll come to you, Dr. Sharma, and a little bit more about expanding on this area. You are an obstetrician and gynecologist. So what do you see in women? Who are the most affected by anemia?
Yeah. So if I want to start by saying who are affected, so I'd like to cover the entire spectrum of women that I see in my practice. And I would start by saying the adolescents. And you would be actually surprised to know that more than 50 to 60% of adolescents in our country have anemia. And anemia, as you said, is actually lack of blood, lack of iron, and a hemoglobin which is less than 12 gram%. And if I go on to the pregnant women, it is actually the prevalence is up to the, again, it is between 50 to 60%. And the surprising fact is that more than 50 years of trying to reduce anemia, the prevalence of anemia has not come down either in the adolescents, neither in the pregnant women. So even in the pregnant women, it is up to between 50 to 55%. And in some areas in India, like, you know, the eastern part, the northern part, 8 out of 10 adolescents are anemic. So it is that kind of, you know, the prevalence of the problem is that, you know, it is prevalent up to 80 to 90% of adolescents in certain parts of the country. So it is very right, and it is very meaningful that we are talking about this problem right now.
And if I add elderly to that,
Yes.
we know that elderly are definitely prone to anemia. Sometimes the kind of patients we see with chronic disease, multiple comorbidities, anemia is quite common in the elderly,
absolutely.
you know, and actually impairs their recovery from so many conditions that they face. So it's actually through the lifespan,
Yes.
it seems that anemia is common,
Yeah.
and particularly nutritional anemia
Yes.
in our country. But Dr. Seth, you know, anemia is not just the one diagnosis. You know, anemia, as Dr. Sharma said, up to 80-90% of the population in some segments or some age groups can be anemic, but it's not all the same. So there are degrees of anemia. So some require more urgent attention, some require just some dietary modification. You want to expound on that?
So, first of all, you can be iron deficient and not be anemic. So, it starts out with iron deficiency, and that can be checked by doing blood tests to look at people's ferritin. And even iron deficiency without anemia compromises people's immune function and other cellular activity in the body. So, iron deficiency itself is a disease.
So that's actually very important, because that's something we are seeing a lot now, because iron studies are being done more commonly.
Right.
And very often we are surprised to see a reasonable hemoglobin and just a low iron or ferritin.
Yeah.
And then, you know, we wonder which way to go, how aggressive to be. So
it's just a matter of time. If you leave these people, they will then become anemic, because now the iron deficiency is of such a degree that they end up being anemic. Initially, they could be mildly anemic when the hemoglobin is between like 10 to 12. Then you have moderate anemia, and then severe anemia is when the hemoglobin is less than 7. And that can lead to even cardiac failure, and in some cases even death. We have patients who come with hemoglobins of 2 and 3 and hypoxic encephalopathy, which is sometimes irreversible. So anemia is a very serious problem, and it should not be taken lightly. The anemia can be intergenerational. So if a mother is anemic, her baby will be born with limited iron stores. So that child is now going to start life already with a very big handicap.
that's a really important point again, and we'll come back to pregnancy and anemia, but I think the points you're making are very relevant for the population at large, both for individuals who are listening, but also for people who deal with policy, that we really need to address this problem in our country. What are the usual signs and symptoms, Dr. Seth?
So often it will be tiredness, lethargy, lack of interest. In children, often they become hyperactive, or they will not be very interested in their studies. They can forget things. So these are very important signs and symptoms. And then if it's going on for a longer time, pica, which is eating unusual things like clay or ice, often that compounds the problem, because if you're eating mud or clay, you can get worm infestations, and that will then further compound the anemia and iron deficiency.
So interestingly, the initial symptoms are very non-specific. And a lot of patients complain of fatigue, tiredness, and sometimes or often actually anemia is the cause and is overlooked unless some blood tests are done or a good clinical examination is done. So what about women, Dr. Sharma? You know, how does anemia impact women at different ages? You said that it is prevalent across the lifespan of women, particularly in our country. How does it impact them?
Right. So as Dr. Seth just mentioned, you know, in children, it might just manifest as lack of energy, lethargy, and, you know, pica. But as they grow up, you know, and they are in their reproductive age group, and they are in their school also, you know, there is actually the school performances, they do come down, their lack of concentration. So anemia does manifest even in the adolescent age group. And as you know, in pregnant mother, we do come across pregnant mothers and who are severely anemic. And one of the greatest impact of anemia is seen in pregnant mothers. So they can have babies who are growth restricted, they can have problems of preterm labor, which is like having a labor before time, and they can have other problems like postpartum hemorrhage. And I would like to mention here that in mothers who die during pregnancy or labor, anemia has been found to be a cause in up to 40% of the cases. So such is the impact of anemia. So a mother who begins her pregnancy with a low hemoglobin is at a much higher risk of having adverse maternal and fetal outcomes. And an interesting fact also I would like to highlight here is that an anemic girl gives rise to an anemic mother. So it's also the other way around. So it's a vicious cycle. An adolescent who's anemic, whose stores are not corrected, whose anemia has not been corrected, who goes on to become an anemic mother and eventually gets a pregnancy which gets complicated. So it is important to correct anemia right in the adolescence and make sure that she doesn't get pregnant before her anemia is corrected.
And during adolescence, if we want them to realize their full physical and mental potential, is very important for the right amount of oxygen to reach everywhere.
Absolutely.
And if your red blood cells are lacking or hemoglobin is low, you won't get enough oxygen. How will you produce athletes or champions if population has so much anemia? So I think those are very important areas. And a little bit more about the impact on the child.
Yes.
When the mother during pregnancy is anemic, what happens to the child?
So as I mentioned here, so the fetal growth restriction has been found to be seen if the mother is anemic. So fetal growth also depends on the oxygenation. So the baby's growth potential also gets hampered. So it's important that the mother has good stores of oxygen and good stores of hemoglobin. So very important to have a good hemoglobin level during pregnancy.
So pre-pregnancy checkups, when they are done, should always look at correcting the hemoglobin by whatever the deficiency is there, whether it's iron or folic acid, or folic acid,
B12.
of course, has other roles also, and B12. So that should be corrected pre-pregnancy and should be maintained like that throughout pregnancy. That's not very expensive, but it's quite a challenge actually to do it at a community level. And I come to you, Dr. Seth, is we're all discussing anemia is common in India. It is definitely a public health issue. Can you expound a little bit on that? What is the data about anemia in India? And
So we have recently had the NHFS data, which has come out, and unfortunately, it has shown that the amount of anemia has increased in women and children from the NHFS 4 data. So we're not really sure why this reason is there. Unfortunately, the NHFS does not look at the etiology of anemia. So it could be an increase in nutritional anemia, but it could also be the other anemias that I've been talking about, for example, sickle cell disease, thalassemia, the other types of anemias may also be included in that. But definitely, I think even though we have some excellent programs on iron, I think we still have a lot of messages, particularly related to food choices, which have not really come across to the patients that we see. Often when I talk to families and I say, can you name me 3 iron-rich foods, I get no answer to that question.
Yes. So a lot of effort needs to be put in this direction, and it clearly is a significant problem affecting both sexes, but in particular women, and with all the impact that we have heard about. But how do you treat anemia, Dr. Sharma? When you see anemia in an adolescent or a girl or in a pregnant lady as an individual, and what do you think can be done at a larger population level to tackle this problem?
So first I'd like to talk about the at an individual level. And before I go on to the treatment part, I would like to talk about the prevention.
Yes.
So prevention of anemia is actually something that we should all focus on. So when we have a woman who's pregnant, any pregnant woman should be advised 3 things. So one is that she should be taking a routine supplement of iron and folic acid. So that is undeniable, that is non-negotiable, that she should take a routine iron folic acid supplement. A lot of people feel that, okay, my hemoglobin is 12 gram%, why should I take iron? I start with good stores. If I don't take supplementation, my hemoglobin will fall in pregnancy. That is a given. So take iron folic acid supplementation in pregnancy. Second, as ma'am said, diet is important. Iron rich food is important. The third thing that I would like to say again and again is counseling on when to take iron is important. Even if you take iron folic acid during pregnancy, if you are taking it with food, if you are taking it with calcium, it's not working. So you have to take your iron at least 2 hours after meal or 1 hour before meal, and not with calcium, because then the iron does not get absorbed. So this is very, very important. Number 2, this is for prevention. If you are diagnosed to have iron deficiency anemia, or you are in a range where you have mild iron deficiency anemia, we give them a trial of oral iron if you are in the early part of your pregnancy. So it's very, very important. If you are a pregnant woman, if you are a healthcare provider, hemoglobin is one of the most basic investigations that we advise in the first half of pregnancy. Please give an oral iron trial for 1 month. If you're not responding, go to the nearest higher center. You have the next level of investigations, and now we have the best tool for iron deficiency anemia, and that is the definitive tool of injectable iron. If today, in this day and age, we have ruled out other causes of anemia and we have a diagnosis of iron deficiency anemia in pregnancy and we are not giving injectable iron, we are wasting it. So any case of moderate anemia in pregnancy, in middle and late pregnancy, we should be giving the trial, we should be giving an injectable iron. It's a very strong tool that we have, and we have a very, very strong programmatic inclination towards giving iron injections in pregnancy and postpartum period to treat anemia in pregnancy. This is a definitive management which can bypass the gastrointestinal.
So you're talking a more aggressive approach in the sense, a more proactive approach.
It is absolutely important. Because we have tried oral iron for years now.
Yes.
Prevention, still oral.
Yes.
But treatment, we have to move towards injectable once we have ruled out other causes of anemia.
So I have one comment and one question.
Yes.
The comment is that when we're talking about calcium and iron, they should not be taken together. Another very common condition during pregnancy is hypothyroidism. Remember, if you take your thyroxine pill, it should be taken in the morning, empty stomach. And the iron and calcium should be at least 5 hours after that. So iron and calcium should follow the thyroid pill by a gap of at least 5 hours. So they should come, one should come maybe around lunch and one should come at dinner time. The gap should be like that, because there has to be a gap between calcium and iron also, between calcium and thyroid also, and thyroid and iron also. So that a bit of juggling, but not so complicated as I make it sound right now. The other is that some patients say that they just cannot tolerate iron pills. And some patients don't like black colored pills. Yes. You know, I've seen that when I was a professor, that people in government colleges were not like those iron colored, black colored pills, and they don't like the constipation it produces and everything.
Yes.
How do you tackle that?
So essentially, that's also a part of the counseling when we give iron folic acid, that this is a pill that you have to take at this particular time, and you might face some difficulties. If you are facing these problems, do come back to us. The first thing is that we change the brand. There are different preparations which are available. There are preparations which do not cause lesser GI side effects. So that might be given. Also, there is a policy of giving intermittent iron folic acid rather than daily. That also has been shown to decrease the side effects in pregnancy, and that is what we advise. And of course, if after trying it for 15 days to 1 month, they're not able to adjust again, that's an indication to give injectable iron.
And what about the reactions to injectable iron?
So now we use iron sucrose and ferric carboxymaltose, which are very, very safe in pregnancy.
Absolutely. So we've used those now. It really has changed the administration of iron with better preparations.
Yes.
The reactions have gone down, allergies have gone down. So that's an amazing tool. I would like both of you to comment one by one. Dr. Seth, is about how do we approach this public health issue? And what are the strategies one can adopt to deal with this?
So the government has come up with some really good strategies. So one is, in the school, they are giving weekly iron and folic acid to adolescents. There's a lot of programs where they are screening for anemia and giving iron and folic acid supplementations. Another very innovative thing that I found in some of the programs is that they are encouraging the use of iron knives and iron cooking utensils. And in fact, there's a very good study from Africa where they found that vegetables or even cereal cooked in an iron vessel actually contained more iron than meat that was cooked in a regular vessel. So this is a very sustainable way of giving iron, particularly to families which may not have access to too much fruits and vegetables. And the diet is also really important, just as you had said. And so it's very, very important that we talk to communities about developing kitchen gardens. You can even grow things in pots, and improving their diet by good choices and knowledge. So often we have families, particularly at my hospital, who are not very rich and they can't afford very expensive or fancy foods. But I spend a little time in encouraging them to make good food choices. So you can pick foods which may be inexpensive. So for example, pomegranate, everybody thinks is a very iron-rich food. However, it has much cheaper alternatives like watermelon, pomegranate, custard apple, which could be cheaper and more locally available, which have many more times the iron. And even in vegetables, by eating the leaves of the vegetables, so eating beetroot greens, radish greens, cauliflower greens. So cauliflower everybody eats, we don't eat the leaves. But if you can eat that, then without spending any extra money, you are improving your diet. So simple messages need to be ensured that the people understand and get these messages, and doing simple things like kitchen gardens and things, they can vastly improve the quality of the food that they're taking. Because if somebody is very truly iron deficient, even taking one iron pill a day is not going to replace the deficiency. They will need to take 2 or 3, which usually is impossible. So by improving their diet and taking an iron pill, we can get over even severe iron deficiency. So I just wanted to say about the iron sucrose and the ferric carboxymaltose. These are agents that we have used in very elderly geriatric patients as well as even in the pediatric population. And in pregnancy also, they are completely safe. A lot of older people have the idea that we're using iron, which is very dangerous, but those were the intramuscular iron dextrans, which are completely banned now. They're not allowed.
So what about pushing things to the public? One is awareness, of course, that's the longer route. Sometimes, like we did in the case of iodine, you just add iodine to salt and it reaches people and at least brings them to a particular level, maybe not to perfect levels. Yeah. What do you think about that?
So again, that has been taken up by our government, and in many countries, they actually have wheat flour fortification. And our country, we've now started rice fortification with iron, and that is a very good step that is being done. And it's important to, a message that I just wanted to convey is that some people are afraid that this might be dangerous. This is not dangerous at all, and there have been a lot of studies to show that this is a very safe practice, and there's very little risk of getting iron overload from these supplementations, because the quantity of iron that is given is very well thought out and researched, and there's very little toxicity that can happen. It's a safe and effective practice and will help the poorest of the poor.
So, Dr. Sharma, coming to you near the end of the program, again, what is your recommendation in addition to what Dr. Seth has said? A and B, could you quickly enumerate some food items that people should consume once more towards the end?
Yes, so I think ma'am has told a lot about diet, so I thought I will just stick away from the diet.
Yes.
And I would say, yes, the first point is diet, which madam has told very, very elaborately. But I'd like to add 2-3 more points.
Yes.
The first is deworming. I think Anemia Mukt Bharat program has really done wonders in terms of the interventions that should be done. And it talks about 6 interventions. And first, of course, is the iron folic acid we have talked about in detail. The second is deworming. Any child, adolescent and women, pregnant women should be dewormed. That is a public health intervention, should be done across all age groups. The third thing that I would like to talk about also is fortification, which is being done as a midday meal school program, and of course it should be done. The fourth thing that I think also is a public health intervention, and that actually we have experienced going out into the community, is connecting with the ASHA workers, talking about them, about the awareness about the anemia program. And this actually works because if you create awareness, ASHA workers are the backbone of our community program, and you tell them that you get your hemoglobin done and you get the hemoglobin of the pregnant woman, and you come back to us for injectable iron if your pregnant woman's hemoglobin is less. So I think we need to create this awareness among the ASHA workers and make them aware of the impact of anemia, and that is what is going to really work for us. So that is one additional message, and one more important message is delayed cord clamping. Delayed cord clamping at the time of birth is a very, very important intervention right at the time of birth for prevention of anemia among children and adolescents. So I would say that these are some of the very important interventions which have worked in the states that have actually looked into, with Anemia Mukt Bharat, have somewhere they have been enumerated and they have shown to work in various studies, and even in bigger pictures and in certain states they have shown to work. So I'm sure with concerted efforts and programs like this, creating awareness for these small interventions, I'm sure we can really count on these interventions to work.
Well, thank you very much, Dr. Sharma. Thank you very much, Dr. Seth. It was really wonderful to have our viewers listen and see you talking about anemia, especially in women, to realize how major this problem is in our country, how significant it is, how it should be tackled at the individual level with a variety of new treatments, including more free use of injectable irons, and of course at the public health level by various measures, of course dietary diversification, awareness about that, awareness about testing, and also fortifying the right foods. Thank you.